Thank you. And so this is my topic, evaluation of CT scans of cancer immunotherapy patients and RECIST versus irRECIST and iRECIST. These are my disclosures. And next 25 minutes or so, I'd like to go over these 4 items. First, I'd like to really introduce and emphasize the concept of imaging as a common language to assess tumor response to therapy. And then with that in mind, I'd like to go over immune-related response evaluations and go over the criteria that currently exist. And then later, I would like to share with you some of the recent observations of tumor burden dynamics as an objective of marker of immunotherapy. And then finally, briefly touch upon immune-related adverse events as a pitfall for tumor response evaluations. So first, imaging as a common language. Whenever we do a tumor response assessment using imaging, it is extremely important to keep in mind this concept as a common language of tumor response assessment. And this was introduced back in 1981, more than 30 years ago, in this paper by Miller et al. In Cancer that introduced the first imaging-based standardized criteria, the WHO criteria. This paper starts by saying advances in cancer therapy are made by continuous investigation and evaluation of treatment results and their incorporation in the practice of oncology. It has therefore become necessary to develop a common language to describe the results of cancer treatment, and that's how this initial WHO criteria was made. And even though this came out more than 3 decades ago, this still has a very pertinent message for us in 2017. And what it means is, whenever we are providing tumor response assessment on imaging, what we are doing is providing a common language. And so whenever we say response, everybody should be on the same page, how it was assessed, how it was defined, and what it means. And that's the same thing for progression. In terms of the conventional response criteria, the first criteria was WHO criteria, came out more than 30 years ago, uses bidimensional measurement. Later, back in 2000, response evaluation criteria in solid tumors, or RECIST, came out, revised in 2000, that uses unidimensional, mostly longest diameter assessment. And this RECIST criteria has become the standard of tumor response assessment in most of the solid tumors in the nearly 2 decades, and has provided a basis for regulatory approvals of new drugs. Just a few major points of the original RECIST came out in 2000, now called RECIST 1.1. It defines measurable lesions based on its size. And among the measurable lesions, we choose target lesions, up to 5 per organ and 10 in total. So we select them at the baseline, and we use the sum of the longest diameter of all target lesions to quantify the tumor burden on each patient on serial scans. It also defines non-measurable lesions that are lesions too small to measure or are not suitable for repeated measurement, and these are recorded as non-target lesions. RECIST assigns 4 categories of response as shown here, and it provides specific definitions and cut point threshold for response and progression as shown here. And importantly, in RECIST and WHO as well, the appearance of new lesions immediately defined progression. That becomes important later when we think about tumor immunotherapy. RECIST was revised back in 2009, and the current version is called RECIST 1.1. The major revisions are as listed here. It includes reduction of the number of target lesions from maximum 5 to 10, maximum 10 to 5 in total, and from 5 to 2 per organ. Assessment of the lymph node size was also redefined, and for the lymph nodes alone, we use short axis as opposed to the longest diameters, and we need 15 millimeter of short axis to make lymph nodes as a target lesion. Disease progression was also clarified, and in addition to 20% increase, we now need 5 millimeter absolute increase in size and to accommodate measurement variability of small lesions after effective therapy. And FDG PET scan has been included in detection of new lesions. And after 2009, again, this RECIST 1.1 has quickly incorporated into the clinical trials of most solid tumors and has become the basis for treatment efficacy assessment and regulatory approvals of new drugs. So with that in mind, we go into the new era, the current era of immune-related response evaluations. As you know, immune checkpoint inhibitor therapy has really become a major treatment option for majority of cancer types, and it really brought a paradigm shift in clinical oncology today. And whenever we think about immunotherapy, it is very important to remember the anti-cancer mechanism of immune checkpoint inhibitors is via blockade of immune inhibition by tumors. And what it means is when there are tumor cells, they already express those immune checkpoint molecules such as PD-L1 that allow them bind to the host T cell and send inhibitory signal and suppress the activity of T cells so that they can escape from the immune attack and they can survive and proliferate. And what the immune checkpoint inhibitors do is to block this binding, thereby activating the T cell so that T cell can recognize and attack and kill the tumor cells as they should be doing. So it has very unique, somewhat indirect, kind of double negative blockade type of mechanism to kill tumor cells that are different from either conventional cytotoxic therapy or even from conventional molecular targeting therapy that usually target oncogenic drivers. And this is the list of the agents and indications approved in the US as of last Friday. And this list is being updated almost week by week, and you can see how rapidly the indication of drug is expanding, and there's more inhibitors and more agents in the development pipeline and early clinical trials. So because of this indirect double negative kind of unique mechanism of immunotherapy, in patients treated with this kind of immunotherapy, unconventional response patterns were noted on imaging, mostly in the initial phase of clinical trials. That included response after an increase of tumor burden as shown here. The tumor increases first before experiencing immune-related response, or response during an appearance of new lesions as shown here. The patient developed this new subcutaneous nodule before that goes away due to immune-related response. And both of those initial tumor increase or the appearance of new lesions qualify as progression by conventional criteria such as RECIST. Therefore, these patterns are often called pseudo-progression. And the histologic examinations of those cases have shown this initial increase is due to the infiltration of immune cells into the tumor, not because of the true proliferation of the tumor, but the immune cells infiltrate the tumor and swell it up. But if you give enough time for it to react and kill the cancer, it will shrink and cause immune-related response phenomena. And the concept is here, similar here. Perhaps there was a micrometastasis that we didn't see. Immune cells gets activated and gather and will become able to see, but if you give enough time, it kills the cancer and goes away. So to capture those unconventional immune-related response patterns, immune-related response criteria, or irRC, was developed back in 2009, and this really introduced a very important two concept when we think about imaging of immunotherapy, and that it requires confirmation of progression on 2 consecutive scans so that we don't prematurely declare PD before the tumor shrinks. And also, it includes new lesion measurement in the entire tumor burden rather than declaring PD at the appearance of new lesions, because some of the new lesions may shrink or disappear later as a part of immune-related response. And so this criteria has introduced a very novel concept, the important concept when we assess cancer immunotherapy. However, there's no question that this was very innovative and important. However, as a radiologist, when I looked at this criteria, there was a little bit an issue. It's mostly a methodological issue in terms of how we measure and how we assess imaging. It is that although this irRC came out back in 2009, this methodologically, it followed the methods of measurements and definitions of WHO criteria that was more than 30 years ago. But as we talked about in the past almost 2 decades after 2000, we've been quickly shifted to RECIST and use unidimensional, mostly longest diameter imaging. And majority of the solid tumor trials have used RECIST to define response and progression. And also many of the studies in the radiology community have shown this unidimensional approach based on RECIST has much higher reproducibility compared to bidimensional measurement used in irRC. Also, this kind of difference is also problematic in terms of the concept of common language, and the issue is shown here. These 2 studies, the 2 papers literally came back to back in New England Journal of Medicine back in 2013, testing 2 different drugs, combination therapy and monotherapy of immune checkpoint inhibitors in melanoma. There is no question that both therapies work very effectively, and both of these agents and therapies are approved as a clinical setting today. However, when they first came out, there was a big debate about which one's working more. Is this shrinking tumor more, or is this progressing tumor more? There is no such way to compare this rigidly in a rigorous fashion, because This trial used bidimensional measurement based on WHO and irRC, while this one used unidimensional measurement based on RECIST. So there's no way to compare these two trials and making it very difficult, these direct comparisons. So when we encountered these issues, we came up with an experiment where we use melanoma patients treated with immune checkpoint inhibitor ipilimumab, and we convert the measurement bidimensional irRC measurement, and we generate another set of measurement using unidimensional RECIST-based measurement, while keeping the important concept of progression confirmation and new lesion assessment as in irRC. And we compared those both bidimensional original irRC versus unidimensional RECIST-based irRC, and in terms of their response results and inter-observer variability. And this is showing the response results comparison by two approaches. These are percent change by bidimensional approach versus unidimensional approach. Each data point represents a percent change of one scan in each patient, and data point in these middle boxes are the concordant assessment. As you can see, majority of the data points are in concordant boxes with a high kappa value of 0.88, showing high concordance between two measurements approaches. There is no evidence of a difference in time to progression by two approaches. And importantly, when we looked at inter-observer measurement variability, unidimensional approach has much higher reproducibility with almost half of the measurement error compared to bidimensional approach, showing that it's more reproducible and therefore more accurate compared to bidimensional assessment. And this, based on these scientific data and subsequent studies, clearly indicated the direction using RECIST-based unidimensional approach to immune-related response assessment. And this approach proposed by our group has been termed as immune-related RECIST, or irRECIST, by the peers of immuno-oncology today. And it basically follows RECIST 1.1 for all the measurement strategies, but continues to keep the important concepts of irRC in terms of new lesion measurements and progression confirmation. And many of the recent trials of immunotherapy has based on this approach in terms of their response assessment. And finally, very recently, back in March of this year, RECIST Working Group introduced the dedicated criteria for cancer immunotherapy, designed for cancer immunotherapy, called iRECIST. This also follows a direction that has been proposed by our research in terms that it bases assessment methods mostly for RECIST 1.1, but it has several important concepts as well. So one of the important concepts is this unconfirmed PD, or IUPD, which is a progression by RECIST that remains to be confirmed, and that can become confirmed PD if the next scan in 4 to 8 weeks shows further increase. They also revised and updated the recommendation how to assess new lesion assessment, and new lesion assessment instead of adding the new lesion measurement into the sum, the new lesions are recorded and measured separately, but it can also confirm PD if additional new lesions or increase of new lesions are noted in the next scan. So this is a summary of immune-related response evaluation strategies, how it started from 2009 to today, and hopefully going into future, we are coming toward more unified approach, but based on RECIST, unidimensional-based approach, having RECIST 1.1 as a standardized measure for the background of all of these assessments. So with those in mind, I'd like to share with you some of the recent observations of tumor burden dynamics during immunotherapy. It is, of course, very important to have criteria and categorize response categories in patients and define time to progression in clinical trials. However, as an imager looking at these cases every day, in order to more contribute in terms of treatment decision-making and guidance, I do think that what is more important is perhaps to look at tumor burden dynamic changes on serial CT scans in these patients. For example, this is about 100 patients with melanoma treated with PD-1 inhibitor, and their spider plot shows their tumor burden dynamics. It is very easy to note these three outliers here. These are probably the first thing that you note. These are the pseudo-progressors. Their tumors initially increase and then decrease. Although it's important to note the incidence of this. This is 3 out of 100, so it's only 3%. It's not a very common phenomena, even in melanoma. But let me look into it. So there are 3 patients. The important thing is that All these patients had several scans showing tumor burden increase before experiencing immune-related response, meaning that these patients will qualify as confirmed PD, whichever the criteria we use, and that clearly indicates a current limitation of the immune-related response strategy. And this is one of the cases here. The patient has multiple scans with increasing tumor burden, and it's very difficult around here to say this is either pseudo-progression or true progression, and clinical dialogue with the clinicians will become important. Perhaps many radiologists in the room would say here there's a tumor density is decreasing, and you can sort of hallucinate some shagginess in the fat. So yes, at this point, we may be able to suggest something is going on. However, unfortunately, this doesn't happen in every patient. This is only a subcohort of patients with pseudoprogression. Not all pseudoprogressors exhibit this kind of appearance. So we clearly need something that can tell us early on during the therapy course that if this is a pseudoprogression or true progression. But still, it's only 3 out of 100. These are outliers. So if you look at this graph and try to neglect those 3 pseudoprogressors, there's clearly another subset of patients that is distinct, which is those patients whose tumor burden kind of stays similar to the baseline, or less than 20% increase of the baseline, that are definitely having prolonged response and durable treatment benefit, and seems to be living longer. So we looked at this cut point of 20% increase from the baseline as a marker of treatment benefit and survival. And we built 2 statistical models using 3 months landmark analysis as well as Cox model, and both analyses showed that this 20% increase from the baseline is associated with longer survival, indicating that this can be a practical marker of treatment decision guidance, meaning that as long as the tumor burden stays less than 20%, the therapy can be considered having benefit and keep going with that therapy. And we're trying to validate this finding as well as testing this in different tumor types, such as lung cancer. So this is a spider plot of 160 patients of lung cancer treated with PD-1 inhibitor. There's one case of pseudoprogression, 1 out of 160, which is less than 1%. So pseudoprogression, very uncommon in lung cancer, at least treated with PD-1 monotherapy. It's very important to note that. But because everyone do want to see the pseudoprogression, I will show this one case. As you can see, this patient as well had several scans showing tumor increase before start to experience tumor regression due to immune-related response, again achieving confirmed PD, indicating the limitation of current strategy. Similarly, we also tested the 20% increase from baseline as a marker for survival in lung cancer, and as well this has association with longer survival, meaning that this could also be a practical marker in lung cancer as well. Another important concept that came out recently, introduced by French group, is this concept of hyperprogression, where the tumor growth rate before and after therapy doubles. So tumor growth rate after therapy more than doubles compared to the growth rate before therapy. And I personally believe this is still a very new concept, but I personally believe this is very important because we see some rapid progression with dramatic tumor burden increase anecdotally in some of the clinical patients. Like in this case, this is a lung cancer patient with liver metastasis at the baseline. Only after 8 weeks of starting immune checkpoint inhibitor, you can see an explosion of tumor burden. Of course, there's always a debate that this was an aggressive tumor to start with, but still, this is who's gonna experience this more. The clinical factors and biomarkers of this kind of phenomena is also important as well. And then finally, just a few words about immune-related adverse event as a pitfall. I can't emphasize more how many things happen when you give this kind of therapy that kind of grabs the basis of immune system of the patient and modulate it. Almost anything that you can imagine in the autoimmune setting can happen from head to toe in various organs. And many of these toxicities have specific imaging findings, and it's very important for radiologists to be familiar of these findings. And some of them can be tricky in terms of response assessment, such as this sarcoid-like lymphadenopathy when the lymph nodes swell up due to granulomatous inflammation, not due to tumor. It's sometimes tricky to differentiate with metastasis, and this requires careful look of the comparison of images and how the tumor looked at the baseline, how the tumor elsewhere behaving, and also a dialogue with the clinician. Similarly, pneumonitis is another big issue because they are clinically serious and potentially life-threatening. They tend to come up with these multifocal parenchymal opacities, and it's very important to make accurate diagnosis for radiologists because these can be life-threatening, but if diagnosed early and treated accurately with steroids promptly, most of these cases respond to steroids very well, and it's also very important to differentiate this from other entities such as infectious pneumonia or tumor involvement or lymphangitic spread. So in conclusion, imaging serves as a common language for tumor response assessment during immunotherapy. Awareness of these phenomena, criteria, and pitfall is essential as we as radiologists play practical roles at the front line of cancer immunotherapy. Thank you very much for your attention.